Good morning, ladies and gentlemen. It's my honor and pleasure to be with you today in Arab Association of Study of Diabetes. Thank you, Professor Inas Sheltut, and the organizing committee to giving me this opportunity. C-peptide in clinical practice. We uh, used to have the measurement of the blood sugar beside uh, So we have used to know the type 2 diabetes and differentiate between type 1, looking for the high blood sugar, age of group, the prevalence, genetic predisposition, and nutrition. So if the sugar very high and patient in young age group, insulin deficient, we treat him as type 1 diabetes, while they will get, of course, the autoimmune destruction markers. Using type 2 diabetes in diagnosis in a patient with the lower sugar or slower progression in the level of the sugar, and in his age group above 35, we treat them as type 2 diabetes. For this, we can differentiate the categories to the most common type 2 and less common type 1. While gradually we used to have the C-peptide. C-peptide, it is the amino acid that link A chain with beta chain. And by this link also, it will show that accurately the beta cell function by the steady state for the C-peptide, which is even longer for insulin and not metabolized like insulin in the liver. So what is representing C-peptide is the beta cell function. So either we use it for diagnosis, especially if there is elevated level like in insulin resistance. Of course, it can be elevated in other diagnoses, but about today's lecture, we will talk about the type 1, which is deficient insulin secretion, represented by C-peptide, and insulin resistance or type 2 diabetes. The level we are using usually below 0.2, and this comes from many studies. We will discuss it soon. So absolute insulin deficiency in the level below 0.2, and the MODY type 2 diabetes in the level above 1.1. By this way, we can differentiate if they are above 30 years and they have high level of C-peptide, they are type 2, with the below 0.2 level and below age of 30, they are type 1 diabetes. Whether using the fasting insulin C-peptide or the random one, this study by Berger show that, in conclusion, the random C-peptide level is more powerful than fasting C-peptide and glucagon stimulated C-peptide distinguishing type 1 from type 2 diabetes. Using again the measurement of the C-peptide creatinine ratio in urine is highly correlated with serum C-peptide measurement in the mixed meal tolerance test and insulin treated diabetes. And this is a group by Levison, and they studied 2,800. They find out that C-peptide at diagnosis a much stronger predictor of type 2 diabetes or MODY than age or glycemia. Almost 99.8%. The group also look that C-peptide is superior to the age and BMI in discriminating autoimmune and non-autoimmune diabetes. Is highly correlated that C-peptide level with the antibodies presence or absence in diagnosis. Katz group also, they repeat many studies and they found very predictive value for type 2 diabetes diagnosis as well type 1 diabetes. Not this only, but even longevity. So the time of measurement also is important. The long duration diabetes type 1 diabetes median age 34 years old may account for high performance of the low threshold in predicting type 2 diabetes. So here the using of the urine C-peptide also equivalent to the level of C-peptide random sugar or fasting to be again high predictive value by about 98%. So further than this, a group of prior as well, they did include the C-peptide even for the mixed meal tolerance test, and by even the repetition. So if you do C-peptide frequently for 8 years, you will find different, similar almost results indicating insulin deficiency or insulin resistance. So let's discuss clinical cases. This lady, 39 years old, she's no case of diabetes, had been diagnosed after pregnancy. So it was like diabetes in a pregnancy, being instituted with the insulin because she's pregnant. Later on, they switch off the insulin and they kept her on oral hypoglycemic agents. But unfortunately, her sugar was not controlled. They add insulin, long-acting one. When we check C-peptide, it was low, and then we check anti-GAR65, it was positive, and then diagnosis of the late onset diabetes autoimmune one. We use insulin, 3 doses, short-acting and long-acting, and the patient comfortably become better. If we look for that expected type 2 diabetes, almost 510 million in 2030. 7% of them representing 37 million. And if we consider more control of the sugar, so it will be maybe 15% of these patients using insulin, so 75%. How we can use insulin for this patient in a proper way? In reality, there is 5 clinical features were identified in this group of patients with autoimmune disease. Late onset autoimmune diabetes. So age onset below 50, symptoms, acute symptom presentation, body mass index below 25, personal history of autoimmune disease, and family history of autoimmune disease, usually type 1, diabetes or thyroid disease. According to the UK PDS, even LADA cases between 6 and 10% of diabetes cases, and usually in the age of 35, below 35, LADA may account up to 25% of cases. Let's discuss other case. This boy diagnosed with diabetes at 4 years. He had hypermetropia, no family history of diabetes, parents are second cousins, glucose at diagnosis 23, and C-peptide high. So this is, of course, will not go with autoimmune diabetes. And we check that, and antibodies, GAD and insulin, ICA, all negative. So simultaneously had been diagnosed with anemia, normal MCV, bone marrow biopsy, sideroblastic anemia, thiamine treatment being given for this patient due to his anemia, and his anemia corrected completely. HbA1c become 5.3 on very low dose of insulin. So this is the monogenic diabetes, means single gene mutation. It causes diabetes, and like in this condition, anemia, or other maybe cardiac events or whatever. How we can find these cases and pick from type 1 diabetes? Usually we had to look for C-peptide level. Sometimes even if you need extra confirmation, you can do C-reactive protein. In this study, they saw that HNF-alpha, they have very low CRP. So if you do CRP and find it very low, will give you positive with the high C-peptide indicative of CRP could be really diagnostic discriminator for maturity onset diabetes of the young due to the HNF1 alpha mutation. Other tools for diagnosis used by Exeter University, when they had Chatterjee group and their team, they had been make a lot of the criteria for maturity onset diabetes of young, or insulin resistance type 2 in young, and that also depends on the gender, diagnosis age, BMI, HbA1c, parental history, time to insulin treatment. Further than this, they take them to the genetic testing, depending on the first point is the measurement of C-peptide. And can you look here? This is early thiamine treatment for anemia, SLC19A2 gene mutation. This is done by Mr. Keshab Patil. I discovered the case in Turkey, and they diagnosed it and treated properly. So it can even personalize medicine. So in neonatal diabetes, you need high dose sulfonylurea in this group of mutations, low dose sulfonylurea in this group. And again, you can predict an explanation for associated clinical features like heart disease, gut and gallbladder atresia, microencephalitis, hypothyroidism. Again, you can anticipate clinical features, looking for further problems and early intervention for comorbidities like supportment for development delay, early thiamine treatment for anemia, early bone marrow transplant for severe monogenic autoimmune etiologies. So you can look here that C-peptide is very important to be the cornerstone in steps for MODY genetic testing. So we don't need to do a lot of expensive tests if the C-peptide very low. By this way, also Hattershi and Patel, they did this guidelines for MODY probability calculator, and then you check the C-peptide, which costs you maybe 10 pounds, okay? And then you go for MODY genetic testing, looking for the treatment for this group with low dose sulfonylurea, no treatment required, or because good prognosis and HNF1 beta, which need insulin. So again, treatment in MODY also different by studies show that glycosides are very effective in this group of patients rather than metformin. And by this, we can say that and conclude that C-peptide is one of the most important measurements to discriminate and differentiate between insulin secretion, whether in young or old. By this, we measure the C-peptide. If the C-peptide negative, and if any antibody is positive, this is type 1, while if it is type 2 and C-peptide positive, older patient, they have LADA. In conclusion, random C-peptide can be used in differentiating type 1 from type 2 and more predictive than glycemia, age, and BMI, which is as effective as urine C-peptide creatinine ratio monospec urine test. C-reactive protein can discriminate HN-alpha MODY. If it is very low, diagnosis of LADA can encourage early insulin treatment, and early diagnosis of MODY can change method of treatment, of course, as we explained. Thank you very much for your listening, and I'm looking for your questions.